I'm Mary James from the University of Michigan, and certainly the problems that people have with assessment tools and their variation is something that is widespread in Michigan and Washington and a few states. We're up to, I think, 11 or 12 state users that are using a compatible home care tool that helps people compare the population across subpopulations, if you will, within HCBS programs, but also can look at, it's about 50% overlap with the nursing home minimum data set. And that tool is something that's available to any state that wants to use it without charge through INTERI, the folks that initially developed the minimum data set. And in Michigan, one of the things we're doing for this center is trying to look across our different waiver programs. We have a paper we're working on to using that tool, because it's used in the our PACE program. We did a survey of a cross-section of our personal care program, our home and community-based waiver program, and our state-funded program for the elderly to look at those populations and how different or the same they were. So we're going to have those findings out pretty soon. And I guess the main take-home message that I would say is that the things that you think are different, for instance, longtime users of nursing home services in Michigan, their case mix is about the same as the people in home and community-based services. It isn't. The idea that they're costing a lot more is just, I don't see it in our data, in our evidence. So there's a lot to be gained if we start talking the same language and developing a common language. And I work with a group of people that's been trying to do that. And I'd be glad to talk to anybody that wants to talk about it.
Good. Thank you. Mike Collins.
I think there's several factors that Mike probably brought up. One is the cost. If you do it like Washington State does, where you're using registered nurses that work for the state, I think you have more consistency than some states that have a county intake system, and it's different county to county. And assessors are human, where you were developing different tools for people to try to make them more consistent. But on a bad day or a good day, you might get a different assessment from the same person. So we all have to realize there's going to be discrepancies in the number of hours of service or the number of days that an individual is able to obtain from a system. And we're dealing with the same problem on our deinstitutionalization efforts for people who are in ICFMRs and other institutional settings now. And we've developed several tools, a statewide tool, and of course in independent living centers, just usually ask the question, would you rather be home than here? And that gives a very positive answer in many cases, and that should be enough. But we do need to develop a tool that is universally acceptable to everybody on both sides of this fence, and also make sure that it can be universally assessed no matter who's using it. So it's a big challenge, and I'm glad you're working on it, Mary, and I know that several states have spent millions of dollars in trying to get this done, so let's keep it up.
Right. Okay, other questions, comments? Or,
Hi, I'm Nancy Miller with the University of Maryland, Baltimore County, and I wanted to go back just briefly to the question that Bob Kafka raised related to the approach for people who are in intermediate care facilities for the people with mental retardation relative to older and working age people. And we have done some work trying to look within the waiver program with Martin and Charlene, looking at what some of the differences are in how states make decisions and investments for people with developmental disabilities relative to older and working age people. And one of the things that we noticed in that work, and we were looking specifically at the 1915C waivers, was that states in their systems for people with developmental disabilities have substantially reduced institutional bed capacity on the order of 70% or so over about a 7-year period. And if you look at institutional capacity in the nursing home world, that's only come down about 2%, and that in fact kind of those bed capacity issues were much more significant in explaining expenditure patterns for people with developmental disabilities relative to what they were with older and working age adults. So I think there are some some things that we know that can help us think about how we might move forward more with some populations. And you see that actually was played out a little bit in the Money Follows the Person demonstration, and a real emphasis there in kind of rebalancing and addressing kind of the institutional side piece of that, which I think is critical to making some forward movement with different populations.
Yeah, that's a very good point, Nancy, and bed capacity is something that can be changed through state policy, so.
Mike had-
Okay, Mike Humphrey?
Bob.
Yeah, Mike Humphrey with the Sonoma County In-Home Supportive Services Public Authority in California. I'd like to hear a little bit more, probably from Martin, regarding the personal care option benefit and what your research was in terms of looking at states and doing some state comparisons about expenditures. And I don't know if you've had conversations with states about what their experience was like in terms of securing the personal care option benefit. I know we have that in California, and as I recall, it was an extremely cumbersome process and involved, several state officials having 2 or 3 weekly phone calls with CMS over the course of 6 months, and just to reach the terms and agreements for the personal care option benefit. And I'm just wondering what is discouraging the other 20 states that don't have the personal care option benefit to move forward with that particular process. And one of the things that helped in California that kind of moved the process along quicker was our governor's Schwarzenegger's connection to the current administration in Washington. I know generally the personal care option benefit application process takes a much longer process, and I think it moved through quicker because of political connections. And so I'd like to hear more about that. The one other thing I wanted to just comment about before you answer is in California with the In-Home Supportive Services Program, which serves nearly 365,000 consumers, probably my estimate is, and this is just an estimate, probably about 15% of the individuals served are individuals who do have psychiatric impairments. So I just wanted to acknowledge that.
Yes.
So,
Very good point. Okay, Martin, you want to?
Okay. In the spirit of full disclosure, I should say that we haven't actually conducted a study of states asking them why they have or haven't actually applied to have a state plan personal care optional benefit. So we've only collected data from those states that actually have got the program in operation. And we don't know anything really about the process involved in actually getting that program underway and setting it up. That's not something we've looked at. Although in a paper that is going to be coming out in the journal Inquiry within the next couple of months, we did do a focus study of personal care provision within waivers and the state plan program, and we looked at the determinants of expenditures and participant rates and the variation between states. And one of the interesting findings from that was that there are actually 2 states that have a state plan optional benefit program on the books, but don't actually report any expenditures or participants on it. And it's Rhode Island and one other, it's escaping me now. Now, we haven't actually looked into that, but I don't know if anyone in the audience has got any kind of insight into why you'd have a program that's been approved, but wouldn't actually be serving anyone on it. It's not been a focus of our research, but there's funny things that go on. And that state plan benefit program is particularly interesting because from our survey, we've also uncovered certain states that seem to be kind of acting, I've got to be careful with my words here, let's not say illegally, let's say against federal regulations, in that it's our understanding that if you have a state plan benefit program, you have to make those services available to all people eligible statewide. And there are some states that restrict their provision of personal care to certain eligibility groups within their state plan programs. And we've reported this in journal articles. And no one has really been able to explain this. And it looks like someone's looking the other way, given that this evidence is now out there. So I don't know if anyone's got any insight into that.
Maybe Rhode Island didn't have anybody to assign to the program.